Good afternoon, everybody, and welcome to today's webinar with Sphere Education, Managing Aesthetic Problems with that is the wrong one, Integrating Minimally Invasive Concepts in Complex Treatment Plans with Dr. Frank Sphere. Just a couple of things to note before we get started. Unfortunately, at this time, we are not offering CE credit for these webinars. Zoom is experiencing high traffic, so should you have any delays in your feed, please bear with us, we will get it fixed. There will be a question and answer portion at the end of the webinar, so please utilize the Q&A button at the bottom of the screen. And should you need any help with your feed, please utilize the chat button and we will help you there. So without further ado, it is my absolute pleasure to introduce you all to Dr. Frank Sphere.
Thanks, Jen. Welcome, everybody. Thank you for taking time out of your day. I know a lot of us have a lot of excess time right now, and I'm sure just like me, all of you are anxious to get back to some form of normalcy, but I appreciate you being here for this webinar and a topic that I think can be very helpful for your practice. And I think in the times we're living right now, actually, this particular topic can be helpful in a couple of ways. One is I think it's going to cover some treatment planning issues that are very useful in your day-to-day practice. But the other thing I'm aware of is when we do start back to work and patients are coming in, patients are certainly going to have complex needs. That doesn't mean they're going to all be able to do them immediately. And so I think this webinar actually fits very well with that, because we're going to talk about what sorts of things can potentially have treatment staged or delayed. And I can tell you that if you can tell a patient, you know, this is going to need to be done someday, but I think you don't have to do it right now. Especially with all the stuff we've all been through. When a patient feels like you're an ally to them, that's a massive practice builder for you, because they're going to talk about your caring and your kindness and your concerns over their situation. So, other thing I want to mention, there's a lot of literature in this particular webinar, and I've put all of it into a PDF document. And Jen is going to upload that into the chat at the end of the webinar, and you'll be able to actually get a link to a Dropbox folder that has all of the literature in it. So don't feel like you need to be trying to write anything down as we go through this, because you're all going to have access to it. So this webinar really illustrates the importance of working as an interdisciplinary team. And so I just want to acknowledge my team members of over 30 years, Vince Kokich, senior orthodontist, Dave Matthews, periodontist, and myself, along with our endodontist and oral surgery colleagues and pediatric dentist colleagues. We had a wonderful 30-year study club. So let's start with what is minimally invasive dentistry. And I think the best description of it was written by Erickson in 2004. And what he said is minimally invasive dentistry is the application of a systematic respect for the original tissue. This implies that the dental profession recognizes an artifact is of less value than the original healthy tissue. And I think the key in that description is a systematic respect for the original tissue, teeth, gingiva, bone, and that an artifact is of less value than the original healthy tissue. In other words, prevention and maintenance of teeth, gingiva, and bone probably is better long-term for a patient than the artifacts that we replace them with. So how are we going to integrate these concepts? Well, I'm going to go through basically a series of different dilemmas that you'll see in practice. And I'm going to show you each of them right now, just so you kind of know where we're headed. So we're going to talk about patients like this with severe apical root resorption. We're going to talk about patients with horizontal root fractures. We're going to talk about patients that come in with existing failing FPDs, like this one, which was loose on the lateral incisor, and the lateral has a post and core and very little ferrule. Do you redo the FPD? Do you place implants? What do you do? And we're going to talk about patients that have isolated advanced bone loss. What do we do with those patients? So those are going to be the four major areas of this webinar. And, you know, typically, if I was just to show you those four examples, you'd say, well, that's pretty easy. We're just going to get rid of the problem teeth and place implants. And that would sort of be the simple treatment plan. But I'm going to suggest that the problem we have is implants don't necessarily cure the issue for the rest of the patient's life. Another way of thinking of it is this. I'm going to give you another definition of minimally invasive dentistry. You know, Bob Barkley was one of the most famous dentists there was in the world in the 1960s and 70s. He was really the father of modern preventive dentistry. And his goal was to impact dental education to alter it from a mechanical perspective into a preventive health-based perspective. And you know, what really motivated Bob to go out and start teaching was when he was practicing, he actually noticed that the patients who came to see him that had been to a dentist actually had fewer teeth than the patients who had never been to a dentist. And he wrote one of my very favorite quotes in all of dentistry. And what Bob said is, the goal of dentistry is to make the patient worse at the slowest possible rate, which means we probably need to think about perhaps in some of these patients that are young with complex problems, we might need to look at them as a staging issue, not a cure issue. So really what's happened, and you know, I was trained in dental school 41 years ago, I got out, and implants didn't exist. And I went through a perio-pros program and implants didn't exist. And then in the early 80s, when implants did come in, we used them for edentulous patients, essentially. That's what they're, you know, Brandemark, when they first came here to the US, that was how we applied them. You couldn't even do a single tooth implant with a Brandemark implant because you had no abutments that had anti-rotation. Around the late 80s, around 88 was when the UCL abutment came out. Suddenly we actually could do predictable single tooth implants. And so when we had a tooth that needed to be extracted, it made sense if the adjacent teeth were great health, don't touch them, do the implant. But then in the late 90s and early 2000s, things started changing and people started questioning, well, why even do things like endo and a post-coron crown? Why not just take the tooth out and do the implant? You know, which one's better, the tooth or the implant? And then if you really look at it today, now there's been a move, a significant move to even think about removing teeth that don't need to be removed as a way of facilitating full arch implant supported treatment plans. So there's been this significant shift since the 1980s in how we think about implants. But in that thought process goes a mentality that doesn't question that whether implants survive for the rest of the patient's life or not. And so how long do implants last? And are they successful or are they just surviving? And I'm a pro implant person. I have some wonderful long-term implant cases. Here's a patient before treatment, and here is 1 year after that canine was replaced with an implant. Here it is 22 years later. It's done phenomenally well. And I have a number of restorations on implants that I did in the 80s that are still very successful. But if we really look at what the literature says, and it's difficult because you want to find systematic reviews that evaluate large numbers of cases. And it's difficult. I looked yesterday to see if I needed to update this slide, but this was a 2015 systematic review using 23 different papers, almost 8,000 implants. The average follow-up time is 13.4 years. To me, that's a problem. 13.4 years isn't very long. You know, if you put in a restoration and it failed in 13.4 years, you'd be going, wow, that's not very good. On the other hand, we have a problem. The success rate and survival rates of the implants is phenomenal. We all know that. The trouble is, it's very difficult to find any studies past 20 years. Myron Nevins and his group out of Boston have a study they published in 18 on a 32-year-old case, but it was one case. And yeah, the implants were doing fine, except they had lost bone down to about the third thread. And so what does that mean if that implant was placed in a 25-year-old? Those are the things we really don't know yet. So important findings from this systematic review: smokers had more bone loss over time than non-smokers. Patients with a history of periodontitis had significantly higher failure rates of the implants than people who didn't have a history of perio. And anterior implants presented more technical and aesthetic issues which is, for all of us that have done anterior implants, know that's absolutely true. So I promise you, when somebody took that right central out, they weren't expecting this as the result after the implant placement. Same is true for that one. Same is true for these two. And so our challenge is implants aren't perfect. They're the best tooth replacement we have, in my opinion, still. If we have to have a tooth replaced, I'd choose an implant, but we still have challenges with them. We have aesthetic challenges and we have biologic challenges. Every one of these cases is infected and suppurating. And if we start looking at more current literature about the biology, peri-implant mucositis, which is inflammation confined to the soft tissue, peri-implantitis is an inflammatory process that includes both soft tissue and the loss of supporting bone. If we look statistically right now at prevalence, depending on whose study you read, almost 50% of the implants long-term have some level of mucositis. And again, depending on whose study you read, anywhere from 20 to 36% have more bone loss than you would expect. So it's not saying implants aren't great, but implants do have complications. Now, these implants are still integrated. So in a study, they would still be survival. They would be on the positive list of surviving implants. That doesn't mean they're necessarily successful aesthetically or biologically. And this is really an interesting case treated by a friend of mine. Patient had pretty advanced periodontal disease, and they chose to do traditional approach in the maxilla. They did osseous surgery and crown and bridge. And in the mandible, they chose to extract the mandibular posterior teeth and place implants. Here it is at 8 years. Look what's happening to the bone. Look at the maxilla, it's doing great. And again, I'm not anti-implant, but we can't pretend these kinds of things don't happen. So my point being, when we have a younger patient, there may be significant advantages to seeing how many years we can get from the teeth before we convert to the implants. Now, when we start getting into patients my age, if you could get 20 or 25 years from the implants, that would probably be great for me, okay? And what happened in this case is all those lower implants ended up being lost. Now, bottom line is, now you got a bigger problem. What do you do with that? What's next after we have to take an implant out that's lost a ton of bone? And as I mentioned, just one more piece of literature, we often place implants in teeth that have periodontal disease, remove the teeth, place the implants. But we know that there is a significantly, in this study, 4 times more likely incidence of peri-implantitis in these patients that had advanced perio. So my point in that is what I like to call management versus cure. Often in dentistry, what we do is we think that we cure people. And I'm going to suggest perhaps what we need to do is think about what we really do is manage people. We manage people's problems, hopefully from whenever that problem develops until the end of their life. And so the challenge we have is people live a lot longer. You know, in the 1900s, people, the average lifespan in the US was below 45. Now it's up around 80. And so if you're starting to think about treating a teenager, someone in their 20s, somebody in their 30s, somebody in their 40s, they conceivably have 40 or 50 years ahead of them. And right now, we don't really have 40 or 50 year follow-up on a lot of the stuff we're doing. So what it really comes down to then is the concept of, instead of curing the problem that you see, perhaps that problem actually could be staged and treated later. And that's what I want to walk through, is I want to walk you through an algorithm of how to think about that process. How do I decide whether something can wait or not? And specifically, I'm really focusing on young patients or high-risk patients. So I think ultimately it comes down to a series of questions. So let's take the patient with apical root resorption on the lateral incisors. So the first thing I always like to do when I see something that's unexpected is trying to define what is the real problem. And the real problem is pretty obvious. Patient comes in for a new patient exam, you do your exam, you don't find anything, but then you look at the radiographs and you find that. And so this is an interesting patient, because if you didn't have the radiograph, you wouldn't even know she had a problem, because those teeth aren't mobile. So the problem, if I'm really specific, is apical root resorption on a radiograph. She doesn't seem to have any clinical problems. She has a radiographic finding. Are there clinical symptoms? None. I mean, the mobility is literally normal. What was the etiology? Most likely aberrant eruption from the canines. What do I believe is going to happen if nothing's done? I think someday she's going to lose the laterals. When? I don't know. And these are the kinds of things that you really have to ask yourself when you identify a problem, especially a problem on a radiograph, where there were no clinical symptoms. Is you have to ask yourself, how soon is something going to happen? And the best answer for that is, how long has it been this way? How long have these teeth been this way? And typically you don't know. And the reason you don't know is, in fact, because you just saw the patient for the first time and did your initial exam. And so what we really need, ideally for this patient, is we need to get some radiographs from the past. If we could get 5-year or 10-year-old radiographs and we saw that these teeth looked like this 10 years ago, that's massive in terms of what it's teaching you about your need to do something. On the other hand, if you were to get radiographs that showed 2 years ago the teeth look normal, now you'd be definitely moved towards acting much more quickly. And I think then the real question, especially again on radiographic findings, is the problem going to progress? Is this resorption going to get worse? Are these teeth going to eventually, that root going to resorb and the teeth are going to fall out? So if you can think about those questions, and I think that there's some really significant ones, is what is the problem? Are there clinical symptoms? What do you think is going to happen if nothing's done? How long has it been this way? Those are really important questions. So let me show you just a little snippet of her treatment. And I have a number of cases like this, but in this 50-minute webinar, we want to make sure we cover the other topics I listed as well. So I'm just going to briefly go through her. She, in this photograph, is 16. Think about how long she has to live still. She might live till 80, she might live to 90, she might live to 100. I mean, that's a long time. If you put implants in those lateral incisors, will they be there when she's 80? I don't know. If they are, will they look good? Questionable. And so that's what I mean by management versus cure. So here she was when she was 12, almost 13, 12 years, 9 months, she saw Vince Kokich. Vince's first question, how did this happen? How long has it been this way? Well, he needed to get old radiographs. Thankfully, he could get them from her dentist. Here's what she looked like at age 8. What caused the resorption? The cuspids. The cuspids coming in on top of those lateral incisors is what caused the resorption. And by the way, just as an aside, if we saw canines coming in like this, the first thing that our team would typically do is extract the deciduous cuspids. You want to encourage the canine to start coming down more to the distal, not running into the lateral incisor. And sometimes you actually have to get a hold of the cuspid, but typically getting the deciduous canines out can be beneficial in these cases. So what we now know is these teeth have been this way, what, almost 5 years. So Vince is working up his treatment plan, and it's, do I extract the laterals prior to ortho and hold spaces? Do I extract the laterals and substitute the canines for the laterals? Not a good decision because she's also congenitally missing second bis. So if you took the laterals out, moved the canines into the lateral position, and she's missing second bis, that means she'd be missing 4 maxillary teeth. That's not a good thing to be doing for most patients aesthetically or in terms of biologically, in terms of airway space, making a little tiny maxilla. So what Vince chose to do is, they've been this way 5 years, let's see how they do. Let's leave the lateral incisors and see what happens through ortho. So there she was when he started ortho. Here she is a little over 2 years later. Ortho's been completed. The teeth are all lined up. And this is how the roots looked when she was 12-9, and this is how they looked at 15. Okay. Here she is, age 26, 11 years later. The teeth aren't mobile, the teeth are still there, and yet if you look, the roots are incredibly short. But if you look carefully, you'll notice that in fact, the roots relative to the bone, you can tell there's no mobility because there's not even a widened PDL. And what's fascinating about a lot of these short-rooted teeth is they almost feel like they get some kind of fibrous attachment to the bone, and because the mobility is amazingly normal. So there's 12-9, 15, 17, 26. That's what I mean by integrating a minimally invasive concept into a more complex problem. It really says if we can wait on this patient before these teeth are lost and buy time for her, 10 years, 15 years, 20 years, that's a huge advantage going forward because it means whatever we replace them with doesn't have to last as long, potentially. Okay? So when are those laterals going to be lost? Probably following a traumatic event. My experience with these kinds of teeth is it's like the family dog jumps up, hits the tooth becomes mobile, you have to take it out. The other reason would be if she went and saw a new dentist. Because if she goes to see a new dentist, the new dentist is going to look at her and say, oh, man, we got a problem. Now, let's talk about those key questions. What was the etiology? It was the canine eruption. How long has it been this way? She's 26. This happened when she was 8. It's been this way 18 years. Is it impacting other teeth? No. At age 8, it wasn't impacting other teeth. Will it progressively get worse? No. This is pressure resorption. Pressure resorption is what causes apical root resorption. It could be from the ortho itself, but in this case, it was from the aberrant eruption of the cuspids. Pressure resorption is an interesting phenomenon in that once the pressure is removed, the resorption doesn't progress. So these roots are not going to get any shorter. What they are is what they're going to be. But will there be a time perhaps they need to be removed? Yes. And typically, when is it? It's when they become excessively mobile. And typically, as I said, that's following trauma. So I would suggest when you see a patient with short roots, a short root does not condemn the tooth to extraction. A short root might mean that the tooth has slightly more mobility than normal, but it doesn't mean the tooth needs to be removed immediately. And oftentimes, especially if you're talking lateral incisors, even taking a little wire and composite and just bonding that lateral on the palate to the canine to help stabilize it is all you need to do. And again, buy time for the patient. Let them understand you're trying to help them. You're trying to see how many years you can get before you have to do treatment. Okay. Next, we'll talk about horizontal root fractures. And horizontal root fractures virtually always come from trauma. It's some sort of a traumatic event. Now, what you have to do to manage them is very dependent on a few things you have to do during your exam. And one of the most important things you have to do during your exam is probe. And as you're probing, you're trying to identify, is that probe going down to the fracture? In other words, is the biologic attachment violated? So now from where the fracture is up into the oral cavity is open. Or in fact, is the tooth fractured and it's going to be a bit mobile, but in fact, when I probe it, it still probes normal all the way around, meaning the biologic attachment is still intact. So here we've got a young boy, typical young boy traumatic accident, horizontal fracture, quite far coronally placed. And bottom line is, if your probing is normal, the only treatment you might need to do is to splint that tooth to the adjacent tooth. How long depends on how mobile. And so, typically it could be a couple of months. A really mobile one where there's a big space between the fragments, you might need to go longer than that. This one, there's very little space, which means that the coronal fragment wasn't displaced. So I would use things like a wire and composite, so there's a little bit of mobility still left there. But if you probe it and there's no probing to the attachment, these teeth can do incredibly well. They may not even need any endo. Now, if the attachment's violated, you're probably going to have to do endo, at least in the coronal fragment. And if the coronal fragment is just plain too loose, you're going to have to take it out. So what's the risk of giving it a try? And what I mean by that is this. It's a traumatic accident. The patient comes in your office in emergency. You're not going to take the tooth out and put an implant in that same day, typically. You're going to do some emergency treatment and get them back. So splint it and give them a try. Give them a chance to see what happens. The risk would be a loss of the coronal fragment, hypermobility of the coronal fragment, or ultimately the need to do endo. Those would be the typical risks of giving it a try. So what's the literature say? Jens Andreassen's really the father of modern trauma in dentistry. So they followed 534 incisors in 7 to 17-year-olds following horizontal root fractures. They followed them for 10 years. So 80% of those 534, 425 incisors survived those 10 years. That doesn't mean they suddenly then failed. They just stopped the study at 10 years. What was significant was, depending on where the fracture was, if it was in the cervical area of the tooth, that had the lowest prognosis. The more apical you went, the better the prognosis got. So if you took out the ones that had fractures in the cervical area, 88% of those teeth survived 10 years with no treatment other than splinting them. Okay, so here's our young guy at age 17, splinted with some wire and composite. Here he is at age 25, no treatment other than wire and composite. Here he is at 38, 21 years later. And what Andreassen talks about is getting a fibrous union between the coronal fragment and the apical fragment. And you can see, if we look at these radiographs over time, that line where the fracture is virtually starts to disappear, as though those two segments become one again by some kind of union. How long will he keep this tooth? My guess is potentially his whole life. And imagine, had you taken it out at 17, he's too young for an implant. And so at age 17, you would have had to do some kind of tooth replacement. You would have got some significant ridge resorption. And then when he was old enough, somewhere in his 20s, you would have had to augment the ridge and place the implant. And now he'd be on the time frame of how long is that implant going before it starts to have any issues. The beauty of this tooth is it will still erupt as his adjacent teeth erupt. So this is one of my favorite cases to talk about horizontal root fractures, because this young guy, again, typical boy, he's done it twice. So a few years back, he took a baseball to the right central incisor, horizontally fractured it. His dentist that he saw at the time went in and sent him to the endodontist. They consulted, and the endodontist did treatment to do endo in the coronal fragment, and everything was fine after that. And then a couple weeks before this photo was taken, he got hit in the face with a baseball again, same tooth. This time it actually broke the incisal edge of the tooth, and it displaced the tooth to the palate. So this tooth is now lingually placed, which is why on the radiograph you see such a big space between the apical portion of the tooth and the coronal portion of the tooth. Interestingly enough, when you probe it, it probes totally normal. It does not go down to where that fracture is. So yes, the tooth was displaced, but there isn't a connection between the oral cavity and the fracture. He was sent to me to take the tooth out and have a single tooth implant done, but he's 16 years old. Too young for me to think about putting an implant in a young male. So what am I gonna do? He was fine before he got hit the second time. I'm gonna go ahead, I'm gonna move that tooth back where it was, stabilize it with some wire, bond composite on it, and see what happens. I'm gonna give it a shot. So you can see there it is, it's actually to the lingual of his lower incisors. So I just put on some orthodontic brackets. The tooth came out very quickly. I left the ortho and the wire on as my splint. After about, I think, 8 or 10 weeks, I went ahead, took that off, did composite on the right central, and I basically said to him, we're just going to follow this and see what happens. There he was at age 16. Here he is at age 18, 2 years after. Here he is at age 34, 18 years after. And again, not all of them are going to turn out this way, but the only way you find out is give the tooth a shot. Because the challenge for a lot of these younger patients, these teenage patients, or even earlier, is if we take anterior teeth out in them when they're young, we then have to figure out how to maintain that space and replace that tooth for several years. And, you know, in really active young people, keeping a tooth replaced, let's say a central incisor, for a 10-year period in a kid temporarily is challenging. You can bond with wire and composites, usually what I would use, but those kids tend to knock them loose fairly often. And so this way he still gets his tooth. As he grows, the tooth erupts with it. So there he was at age 16 on the left, there he is at age 34 on the right. All right, so now we're going to get into one of the interesting areas of treatment planning, and that is, what if we have patients that come in with existing FPDs and we're trying to decide, do we do another FPD, or in fact, do we convert the FPD, place implants, and do all single units? And so we'll talk about patients that present with existing FPDs that need replacement, typically for aesthetic reasons. And I'm going to give you a fair amount of literature, because the reality is most dentists have strong feelings one way or the other, but they don't necessarily have the literature background to support their feelings. And so what I want you to see is what actual literature about this topic says. So here's a patient who came to my office. She happens to be a hygienist. Existing 3-unit FPD, replacing the left central incisor. We take off the old FPD, and now the question is, she has a really nice ridge. Do we do a single tooth implant? Do we do another FPD? And if we do another FPD, what can I tell her about the 5, 10, 20-year success rate? If I do the single tooth implant, what can I tell her about the 5, 10, 20-year success rate? And what criteria do I look at to decide that perhaps I better not do the FPD, maybe I better be doing an implant instead? In this particular instance, she and I had a discussion about options, and ultimately she chose to do another FPD. Now the question is that a bad choice for her? Would she have been better off with the single tooth implant? Certainly if she wanted the ability to clean and floss, the implant would have been nicer. And there are some cases I will tell you for sure the implant's a better choice. But as I said, I want to give you the criteria of what to look at. So there was my provisional restoration. I created an ovate pontic and used this provisional to form the soft tissue pontic, and then brought her in for the final impression. So that's what that pontic site looks like before I took final impressions. And then there is our final new 3-unit FPD. And she was very happy, and I was very pleased with it as well. That one happens to be a metal ceramic FPD. Today I would do metal ceramics again, or perhaps a zirconia-based framework and an FPD. I love lithium disilicate, but oftentimes it's hard to get big enough connectors to do lithium disilicate FPDs on a bridge like this. Now, this patient comes in, right central incisor is vertically fractured. Left central has no restorations, right lateral has no restorations. It's probing 7s and 9s down where the vertical fracture is. Am I going to recommend to her an FPD and prep the lateral and prep the central? That's not going to be my preference. I'm strongly going to encourage her to consider the implant as a much better choice. Why? Because that way I can leave the central and lateral untouched. And to me, one of the beauties of implants is the ability to not touch the adjacent teeth. So in her case, we took the tooth out, did a single tooth implant and a single crown. I think that's a much better treatment choice for her than the FPD. So let's talk about the literature and talk about what it tells us. So we'll go to implant versus FPD failure rates. We'll start there. And we're going to use a study out of Switzerland. And it's 5 and 10-year survival of tooth and implant supported FPDs. And I'm going to put the numbers up here for you. And then I'm going to circle the ones I want you to look at. Okay. So that's the 5-year survival rate of a tooth supported FPD versus a single implant crown. They're identical. They're statistically identical. Now let's look at the other options in there, which is a tooth-supported cantilever FPD, an implant-supported FPD, so 2 implants and a pontic in the middle, and an implant at one end and a tooth-supported FPD at the other end. All of them are 90+%. Now let's go to 10 years. Let's do our tooth-supported FPD versus our single implant. They're identical. At 5 and 10 years, a tooth-supported FPD and a single tooth implant basically have the identical survival rates. Now, what doesn't have are the tooth-supported cantilevers, the implant, or the implant and tooth-supported FPDs. Those drop like a stone. But our tooth-supported FPDs and our single tooth implants did really well. And what's interesting, and you can find this in a number of different studies that look at tooth-supported things versus implant-supported things, is implant restorations tend to have significantly more maintenance than tooth-supported restorations. What are the most common ones? Porcelain fractures and screw loosening or screw fractures. Those are the most common things that happen with implant-supported FPDs. Now, 38% of these over 5 years, in this particular study, had one of those, either ceramic fracture or screw loosening, whereas only 15% of the FPDs had complications. Now, the question, of course, is oftentimes the complication for the FPD is a bigger deal. It's one thing to tighten a screw as opposed to having to do endo. And so, yes, the FPDs on tooth-supported restorations, if they have complications, the complications are usually bigger deals. And 20.6% of the cantilevered FPDs on teeth had some complications. So what I want you to get out of this particular article, because it did compare everything, a large number of patients over 5 and 10 years, is both FPD and teeth are and single tooth implants are very similar in their 5 and 10 year success rates. And I would also suggest that some of the more modern implant systems, like a Straumann system with an internal connection, they tend to have fewer issues with things like screw loosening, et cetera. I just haven't seen that with some of the modern systems. Now, what things affect the predictability of an FPD? Without question, it's the quality of the abutment teeth. Do they have endo? Do they have a post and core? Or are they vital teeth? Are they 3-unit FPDs, 4-unit FPDs, or bigger? What's the caries history? What's the occlusal history? Those things all significantly impact an FPD. So I gave you some numbers, but I'm going to try and make those numbers a little bit more meaningful for you. So this study's out of Belgium. And it's, again, long-term survival of crowns and FPDs, but it's looking at a comparison long-term of crowns and FPDs on teeth that are vital versus non-vital. Okay, so 10-year survival, tooth-supported FPDs, 92%, right where the other study was. The other study was 89%. 10-year risk for caries on abutment teeth, 9.5%. So out of every 10 FPDs, one of them is going to get caries on an abutment tooth at 10 years. 10-year risk for loss of the FPD from caries, 2%. Loss to periodontal disease, 0.5%. Losing retention on one abutment, 6.4%. 10-year risk for abutment fracture, 2.1. Material chipping or fracture, 3.2. Here's the ones I want you to look at. 10-year risk for loss of an FPD to caries, 2%. Loss of an FPD due to losing retention on abutment, 6%. loss of an FPD because the prep fractured 2%. Those are the big ways FPDs fail. Is not huge numbers, 2.6%, 2.1%, the biggest one being loss of retention, but it happens, okay? Now, what about whether the abutments are vital or non-vital? So this is 20-year survival rates on single crowns on vital abutments and non-vital abutments. The numbers are different, but statistically they're the same. So if you have a non-vital tooth with a single crown on it that's structurally a good tooth underneath, in other words, not gone at the gum line, a crown on a non-vital abutment works well. Now, what about FPDs? There's your 20-year survival of 3-unit FPDs on vital abutments, 83%. What's the 20-year survival on 3-unit FPDs non-vital abutments? 60%. Having one non-vital abutment dramatically lowers the prognosis long-term on a 3-unit FPD. Same on 4-unit FPDs. You see the same significant drop and the same significant drop on cantilever FPDs. So the bottom line is FPDs are really predictable when they have vital abutments. When you have non-vital abutments, and especially if you have non-vital abutments, minimal ferrule, post and core, your predictability drops dramatically. So go back to this FPD where I took it off because it was loose on that abutment, and there is that lateral incisor, minimal ferrule, endo post core. To me, that is not a good case to redo an FPD. And so instead, the patient and I talked about it, and he had the augmentation done, bone and soft tissue, and ended up with single tooth implant. So now the right lateral incisor is just a single crown on a non-vital tooth. Because the literature is pretty clear, when you have abutments that are non-vital, your prognosis definitely drops over 20 years, 10 years. All right, now, what if you know the patient wants another FPD, but you know it is really a high risk abutment? This is a patient who's had an FPD on those 2 lateral incisors for about 15 years. And she lost the centrals in a traumatic accident along with a ton of buccal plate. She's had soft tissue ridge augmentation, so the ridge doesn't look bad, but the bone's terrible where the centrals should be. And so, do I double the butt? And I will tell you that would be my last choice. Those canines are great teeth. I would prefer to not touch them at all. Do I put implants in the centrals? She is very aesthetically demanding, and my surgeon says he does not think he can pull it off in terms of getting enough bone where it needs to be able to get pretty aesthetic centrals. Do I accept the risk and do a 4-unit FPD on those abutments? Boy, the prognosis is terrible. My choice, my first choice, would be to extract both laterals, place the implants, do a 4-unit FPD. That would be my first choice. It's not her first choice. She wants a new FPD. She doesn't want to risk having not good aesthetics with central implants, and she's unwilling to take the laterals out right now. I told her if she got between 1 and 5 years, I thought that would be exceptional. Here she was 10 years out. She's just kind to her teeth. She doesn't have any parafunctional habits. Now, it's nice to show you that photo, but I also have to show you 11 years out. And it did what I thought it would do. They fractured. What did we do? Took the teeth out and did implants. We first actually used the laterals, extruded them some, changed the spacing for the centrals to make them prettier. And now she's got a 4-unit FPD on 2 implants. But she did get 10 years before we did that. Okay. Last area I wanted to talk about, advanced bone loss. And I'm going to suggest to you that periodontal disease is a really difficult thing to predict its prognosis. We don't do it as well as we would like to do it. This is one of the best studies probably ever, Hirschfeld and Wasserman, on 600 patients. They're both periodontists, and these cases were followed an average of 22 years. In those 22 years, 300 of the 600 patients lost no teeth. 199 of those patients lost 1 to 3 teeth. And these are all patients that had severe periodontal disease. That's why they were referred to them. And of the total 2,139 teeth originally were questionable. In other words, both of them agreed they didn't think the teeth would make it. And of those 2,000, 666% actually were lost after 22 years. So periodontally, teeth with periodontal disease actually do much better if they're in active treatment than we typically think they do. So let's take a look at this. And this really is an advanced bone loss case. It's not necessarily a perio case. This is bone loss that occurred because of how those canines were managed when they were brought down. They were both impacted. Here's our problem. She is 17 years old. She was referred to Dave Matthews, my periodontist, to extract the cuspid and lateral on both sides and put in implants. 17. You probe it, it's got class 3 mobility, probes 9 on the palate. Look at that bone loss on the radiograph. Probes 9 straight facial, 6 on the mesial, 17 years of age. And so, as I said, sometimes you just want to give things a shot, and this is one of those times. Because you can always take these teeth out, but you can't put them back. And so the options: erupt the teeth to try and get more bone before you take them out, remove the canines and laterals bone graft, try and place implants, splint the canines and laterals to the adjacent teeth to control the mobility, and attempt to graft. That's what we chose to do. So the key questions: if you attempt to save the teeth, is there a greater risk to any healthy teeth? Not really. If the attempt fails, are the treatment options the same as they were before? Take the teeth out? Yes. If there's minimal risk of damaging healthy teeth and the options remain the same, then the only risk is really time and money for the patient. And so that's their decision. If the attempt is successful, it might completely eliminate the need to ever replace these teeth. So Dave flapped it open. He tetracycline etched the roots. He's using freeze-dried cortical bone with GEM21 growth factor and medical grade calcium sulfate to pack in there. Note the mobility is controlled by splinting. Here it is 2 years post-treatment, 2 years post-treatment, before and after at 2 years, 10 years post-treatment, before and 10 years post-treatment. And I show you that because, as I said, in a young patient, I'm willing to take bigger risks at giving it a shot to see if we win. If we win, it's massive for the patient. Now, do those teeth continue to need to be splinted? I don't know. But we're leaving the splints there because, in fact, she's doing so well. Okay, one more example of isolated bone loss and considering FPD versus implant. And when we look at these kinds of cases with isolated bone loss, you want to know where the existing bone is. What do you think the surgeon can do in terms of grafting? What is really predictable in terms of grafting? Because there's what's possible, which is your home run, versus what's predictable. And then what would be the risk of doing FPDs in pink ceramic? And the bottom line is, on these cases, all of these really challenging, complex cases, you want to try and predict the prognosis before you actually do the treatment. So let's do that for her. Very simple. We know the biology. We know in a human you get about 4.5 millimeters of papilla above bone. So what we really have is a problem of bone loss in this isolated region, about 5 millimeters of bone loss. The tendency when everybody sees this case is they want to extract the lateral and place an implant. The problem is the central has bone just as bad on the distal as the lateral. So if you extract the lateral and place the implant, you don't get anywhere. You just exchange an ugly lateral for an ugly implant. Now, other option, take both teeth out. Well, if you didn't bone graft it, obviously you end up even worse than you are now. So you say to me, but we'll bone graft it. Okay, now comes the question. What's possible versus what's predictable in terms of bone grafting. Typically, I think most surgeons, if they could gain 3 millimeters of vertical height, they would be ecstatic. Now, if you really could gain 3 millimeters of vertical height, and these days I've seen people get more than that, but 3 is a pretty big number traditionally. If you get 3 millimeters of vertical bone height, you definitely improve the situation. So that's a decent option to consider. Okay, there's another option, FPD. Take out the central lateral, do an FPD from canine to the left central, 4-unit FPD, vital abutments. You could soft tissue graft, or you could use pink porcelain. It's an option. Would that get you better? It will definitely get you better. And then finally, there's one other option. What about moving the bone? What about extruding the teeth? Bring the bone down to make the defects shallower, then decide. That's ultimately what we did. We didn't tell her we were going to keep the teeth or remove them because we didn't know. So Vince Kokich is pulling the teeth down slowly. He's now got the gingival margin on the lateral coronal to the cuspid. There's that big dilacerated root. So we stripped the mesial of the lateral and pulled it against the central to pinch the papilla a bit more. And now we get to this stage and it's like, okay, what do you do now? The tissue's looking way better. Radiograph doesn't look so good. Do you take it out? Do you take both teeth out? Or do you give it a shot? We gave it a shot. Took the ortho off. I put on a provisional. I left it for a year. When we put it on, it was only probing 3. A year later, we lost a little bit of tissue is all. I finished the case, single crown, used a little pink porcelain to make up the papilla. I left it temporarily cemented for 6 months so I could pull it off to see what the tissue looked like under that pink porcelain. That's what it looked like. And there she is pre and 6 years post-treatment. Pre and post-treatment, 16 years post-treatment. So there's your 22-year radiograph. And here's your 22 years final result. And what I hope you're getting out of all of these cases is they may look terrible on a radiograph, but you don't know how they'll do unless you give them a shot. And with that, we are going to do some questions.
Yeah, we don't have time for all of them, but I'd like to pick some out. I want to go back actually to being with respect to the posterior implants on the mandibular arch where you had a group of them all together and they were all splinted. Would they have had a better success if they were individual crowns?
I don't think so.
Okay. Do you think you need to anesthetize a patient if there's a horizontal fracture so you can do an adequate probing?
Not in my experience, although I will say that some of them are very tender for sure. So if it's really uncomfortable, then yeah, I would say you will need to use some anesthesia.
Okay. How does a Morse taper connection help to prevent bone loss?
I would not necessarily, it helps prevent bone loss, but it definitely helps prevent screw loosening and abutment screw fractures.
Yeah, and that's probably the loose you were speaking of. It wasn't because there was bone loss and movement. Yeah, exactly. No. Okay. When weighing options of a single unit anterior implant versus an FPD, how do you evaluate aesthetic scores? The study cited referred to survival rate without mention of the aesthetic score.
Yeah, and I didn't put that in, but for sure, the whole pink versus white aesthetic scores would tell us that implants don't do as well aesthetically in the anterior sometimes as we would like. In other words, the pink aesthetic score is not as good as we would like it to be. The white aesthetic score is the restoration itself. And you know, you're going to be restoring, whether it's a 3-unit FPD or a single crown, you're using ceramics. Bottom line for me is it's really a matter of if my surgeon says I can get I can get the right amount of bone in the right place and I can get you plenty of soft tissue, I'm pretty comfortable telling a patient we're going to get a great aesthetic result with an implant. If there's a significant defect there in terms of bone and gingiva and the surgeon doesn't think that they're going to get that result, I would tell the patient if they're really aesthetically driven, I can probably do better with a connective tissue graft and an FPD.
Okay.
Hey, Gary.
At what age?
Gary.
Yes, go ahead.
I'm going to interrupt you real quick and let everybody know that I'm placing the Dropbox link to the PDF onto the chat function right now.
So it's over there. So if you can get a picture of that, that's a lot to type in, but you can get the link. Okay. At what age do implants become considered an appropriate possible treatment, developmentally speaking? And is there a difference between maxilla-mandible?
Well, the rule we always followed basically came from a study at the University of Washington Ortho Department that said females typically don't stop growing until around 17 to 18. So what we would do is at 17 or 18 in a female, we would do a cephalometric radiograph. We'd wait 1 year, do a second cephalometric radiograph, put the two on top of each other. And if there was any change in growth, then we wouldn't place the implant. We'd wait another year, do another cephalometric radiograph. We would basically look for a year where there was no change in the vertical dimension. On males, we wouldn't even start the first radiograph till after the age of 21, typically. In terms of maxilla versus mandible, the challenge of putting an implant in early is that the adjacent teeth are still erupting. So in the maxillary anterior, it's an aesthetic challenge. It may not necessarily be a biologic issue if the amount of growth left is relatively small. But even in the mandible, if you still have several years of growth ahead, you're going to end up with a significant defect in the bone and tissue between where your implant is versus where the adjacent teeth are.
Okay. Hi, Naresh. And when you're doing that tissue form stuff, there was a number of questions, but a couple of these. Do you have to make multiple provisionals, or do you do ridge modification before placing a temporary? How are you getting that tissue result?
The ovate ponic, the way I do ovate pontics is I actually prep the teeth, make a quick impression, pour it out of fast set stone. So I have a stone model of the site. I then take a burr, an acrylic burr, and I grind into the stone model the shape I want the final pontic to be. I then use a matrix, load it with temporary material and seat it on the model. So my provisional is made with the correct form of the final pontic in it. I then go back to the mouth, and now that won't sit in the mouth because the ridge is in the way. So what I do is I take pressure indicator paste, paint the bottom of the ponic, try to put the provisional in, it shows me where it's hitting, and I start grinding the tissue away in the mouth. And basically, and I typically with an electrosurge or a burr, and I shape the tissue until the pontic will seat completely. The provisional will seat completely in the mouth. And then I usually give the patient about 8 to 10 weeks of wearing it, bring them in, take it off, and do the final impression. So no, I don't modify the provisional. The provisional is actually made correctly from the beginning. I just wait for the patient the ridge to heal around it, basically.
Cool. All right. Treatment planning for congenitally missing lateral incisors, fixed partial denture, implant, how to decide?
You know, my preference in a grown patient to replace congenitally missing laterals would be a single tooth implant. My preference if you're not going to do the implant, my preference is actually a cantilevered lateral incisor off the canines. And we know if you do bonded cantilevers off canines, Matthias Kern's research, which is really excellent, where he did bonded bridges, cantilevering laterals from canines, and bonded bridges with wings, both on the canine and the central. And we all know from Maryland Bridge days, what happens is typically one wing comes loose. What Kern did is whenever a wing came loose, he then just cut that wing off and left it as a cantilever. And his 10-year success rate with cantilevered bonded bridges was around 93, 94%. So I think for a young patient, missing laterals, a cantilevered lateral off of a canine, just using a palatal wing is probably the ideal treatment.
Okay. When you add pink porcelain to a single crown, are you not concerned about contributing to periodontal issues?
Yeah, and that's why I showed you that picture where I had left it seated temporarily for 6 months, because I was curious what that tissue looked like. You know, in the era I grew up in, a pink porcelain papilla would have been called an overhang, right? I mean, that, and these days it's a cosmetic enhancement. It's actually not a periodontal issue because it's easy to clean under. You can go take floss, go down, go over to the tooth right underneath it. So it's not a difficult maintenance issue. It's not like a wide coal that you have in a molar.
Okay. I have time for just one more. I'm sorry about that. There's lots of them. Let's do this one. Protocol for orthodontic extrusion. And what it says is removal of PDL and a question mark.
So I'm guessing the question is about, do you do some sort of, you know, go in with a scalpel or a curette and remove the periodontal ligament to try and prevent bone from following, so you can expose the root. That was published years ago by Frank Salenza Jr. And it works. If your goal is to bring a tooth out of bone and out of tissue, so that the tissue and bone don't follow, yes, going in with a curette or a scalpel and going down to bone and removing the PDL, as you now extrude the tooth will come up out of the bone and tissue without the tissue and bone following.
Well, I wish we had time to do all the questions, but unfortunately we don't. I hope you enjoyed this time as much as I did. Frank, it's always fun, you know, to sit and listen, and you have a way of putting things that makes it seem really easy. So thank you for that. Any final words?
No, I would just say that, you know, a lot of what I did in this 50-minute webinar was I actually pulled content from different seminars that we do. And if you're really interested in more of this kind of content, all of those seminars are online. You can see them. They're done in short 15 to 30-minute videos typically. And so any of the particular things like the FPD versus implant issue, all the questions about extrusion example, that question you just asked a minute ago, all of those segments are in our online education. And I would encourage you to just consider going to one of our folks, and they'll even give you a tour of our online site so you can see what kinds of material and what kinds of lessons are there.
Yeah, indeed. One of my friends just contacted me not long ago, and he said, when I first got into Spear Online and I started looking at stuff, I said to myself, oh my God, there's so much stuff. And he said, and then when they told me I wasn't allowed to practice anymore, I sat down and I went, oh my God, there's so much stuff. Thanks, Frank. It was great. Thanks everybody for being here.
Thanks everybody for being here. I appreciate it, and stay safe. And I'm looking forward to getting back to work with all my buddies, just like you all are. So take care.
Bye, everybody.